Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to the Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I'm thrilled to have a wonderful young researcher here with us today who is really ahead of the curve in concussion research and doing prospective studies as opposed to retrospective studies. He's adding age-matched controls and cohorts to his work, and his goal is to equip clinicians with better patient outcomes. Today we have Dr. David Howell. He is a Ph.D. and athletic trainer and is the lead researcher at the Children's Hospital Colorado Sports Medicine Center and assistant professor in the University of Colorado School of Medicine, Department of Orthopedics. He received his Ph.D. at the Department of Human Physiology at the University of Oregon and completed a post-doctoral research fellowship in the Division of Sports Medicine at Boston Children's Hospital. He doesn't like long intros, so in brief, his primary interests consist of investigating clinically pragmatic and objective methods that help clinicians diagnose, manage, and treat sport-related concussion. He has authored studies in peer-reviewed journals across topics of sports medicine, biomechanics, neuroscience, rehabilitation, and pediatric medicine. David, welcome to the Concussion Corner podcast.
Thanks, Jess. It is an honor to be here. Thanks so much for having me on.
Yeah, we're having some crazy, awesome weather here in New York City. It's going to be like 70 in the next day or so. How are you guys doing in Colorado?
We were just at 70, but we got a big snowstorm yesterday, and I think when I was coming in on the train this morning, the temperature was -1 degree, so a little chilly today.
That'll do it, and I'm not missing that weather. I was just at the Super Bowl speaking there, and it was like -20, and I had to be in a dress and heels, and I was probably learning every inappropriate word I could to not. So hopefully it warmed up for you guys. So listen, I'm thrilled to have you on the podcast. I'm really hoping our listeners listen in and lean in to learn from you, just because I have to say, from a complete nerd standpoint, everything that you're publishing just like makes me super excited. I'm a physical therapist, you're an athletic trainer, so it's wonderful to have folks that are working in sports medicine and have been kind of brought up in that ortho sports medicine background, looking at things like near point of convergence with ocular motor issues, gait deficits in adolescents and kids, post-concussion, and just really looking at dual tasking. So I hope our listeners, lean in, and I know they're going to learn so much from you today.
It's great to chat with you, and I appreciate all that you do as far as promoting different professionals in different fields. And like you said, I think it's great to come at things from a multidisciplinary perspective and get the input from athletic trainers and MDs and physical therapists and really anybody else that has clinical insights into the concussion kind of space.
Indeed. And, this is an all hands on deck injury, and it's so wonderful to see all of these wonderful folks like yourself coming together, you getting the research done. And listen, so our listeners know, I have no desire to do what David does. Dr. Howell is doing research wonderfully and publishing that in white papers. My job in this world, I try to fill the cognitive blind spots in healthcare to help folks identify what they very Dunning-Kruger-esque may not know, unskilled and unaware, and promote folks like David who are doing really great research and getting it out there in the world. So let's kick this off and let's give the listeners what they are here for. So every episode I want to start off with very Simon Sinek-esque. His whole shtick is, start with why. I've actually had a lot of folks who don't know who Simon Sinek is, so I'm actually going to start just plugging his YouTube video. It's like a 12-minute TED Talk with like millions and millions of views, so I'll probably start adding those into the show notes. But basically starting with why and kind of how you got into the space and, the trajectory that you've taken to get to Colorado.
Yeah, it's certainly been an unexpected one. As far as concussion interest goes, it certainly goes back to I remember sitting in kind of maybe a 200 or 300 level course in college in an athletic training program at Whitworth University in Spokane, Washington, and going through in the textbook of concussion grades, grade 1, grade 2, grade 3, and then they had some sort of a different table that had to do with return to play guidelines, and they were based on these different grading scales, but there were so many scales and there were so many return to play guidelines. These things didn't really match up at all, and that's mid 2000s about kind of where we were, and kind of at least recognizing like, man, we don't know anything about this. So maybe it sparked a little bit of intellectual curiosity. And then During my time as an athletic trainer, the most vivid example of really not knowing anything early in my career and wanting to know a little bit more was working at high school camps, high school football camps, where time after time again in the afternoon, I couldn't tell if a kid came up to me with a headache and dizziness and what other symptoms. And I couldn't determine with any sort of confidence whether he was homesick, whether he was dehydrated, or whether he had actually gotten hit in the head. And that's really kind of what set me on the path to at least being interested in concussion. And from there, I was fortunate to get involved in my master's project at the University of Oregon with the Motion Analysis Laboratory and get involved with Lishan Cho, who's a gait and balance control guy who kind of took me in and I started as a kind of a clinical athletic trainer there for 2 years and then turned that into a Ph.D. where I was able to learn from some very, very smart people on the role of attention and dual task and kind of that neuropsych side of things, but then also on the motor control and the biomechanics side from Lishan. And then from there, I went to Boston Children's Hospital where I really got a full-fledged education in clinical research, where I was under the mentorship of Bill Meehan and worked with him for 3 years. And the amount of information that I got from him and the way that he thinks about things, as well as the whole team at Boston Children's Hospital, really set me on a good path to at least understanding both the basic science as well as the clinical implications. And then that brought me here to Children's Hospital Colorado and the University of Colorado School of Medicine, where I'm kind of the lead researcher now for all things sports medicine, certainly with a focus on concussion. So without going into too much detail, that's kind of how I got to Denver, where I am now, and I've been here since September.
That's awesome. And, I think I don't know if the stat, I'm pretty sure it's like up to 80% of concussion folks or athletes that have a concussion within a year have a lower extremity injury. Are you familiar with that research?
Yeah. We just published a review article kind of examining the literature to date on looking at the relationship between concussion and subsequent injury. And I think that it's a phenomenon that we're still understanding, and the literature, depending on the study design or the population, has been somewhat mixed, but pretty consistently showing that there is some sort of association between those two things, where those who get a concussion are more likely to sustain a subsequent musculoskeletal injury or at least a time loss injury. And so actually in this review article, we kind of went through and proposed one potential mechanism, which might be dual or attentional deficit, and try to at least just theoretically connect the dots while also understanding that this hasn't been experimentally tested yet, but it's certainly an area that hypothetically has a lot of evidence to support it.
Indeed. And you broke up just a little bit. That was so important. I want the listener to really get
sorry.
that. You said you broke up at the dual tasking point. So your thoughts are the hypothesis is what?
Well, so if we think about the way that dual tasking works, so for those listeners that aren't as familiar, completing two tasks at once. So if you have to simultaneously perform a cognitive task and a motor task, when you're doing each of those two things in isolation, you're going to perform them at a similar level. But when you have to, or at a certain level, but when you have to simultaneously complete them, which is what we call a dual task, we see a trade-off where there's going to be some sort of reduction in performance on one component or the other. And we see that after a concussion, that these dual task deficits continue to persist for a longer period of time, it seems, than a lot of the other kind of traditional clinical measures where we're in isolation measuring cognitive function or balance control or something, even vision, things like that. If we can combine these things, A, we probably increase the sensitivity of detecting some sort of deficit, but B, we're also creating a more lifelike environment that might be reflective of the demands of sport, for example, where athletes have to think and move simultaneously at all times. So if we see that there's some sort of deficit in this dual task ability, perhaps that might be a precursor to risk for another injury in the year following a concussion, for example.
Indeed, and I'm so glad that you brought that up with combining tests and measures, because I know that Laura Balser et al. Put together something in 2014, basically looking at the best the SAC and the KD and the King Devic, and basically they were, basically finding like 100% sensitivity with some small numbers. So I think the future of concussion is very comparable to the musculoskeletal world. For example, we have clinical prediction guidelines, and I don't call them rules, I call them guidelines because we're clinicians first. But if we're combining some things, and gosh, I'm just thinking about even just the shoulder, or even Canadian cervical spine rules and things like that. If we're looking at like rotator cuff pathology, for example, so if we know that, a positive painful arc sign, positive drop arm sign, and an infraspinatus manual muscle test, we can say with, if all three of those are positive, we can say with a positive 15.6% ratio with a post-test probability of 91% that there's a positive rotator cuff tear there. No different than, if they're greater than 65 years of age, they have weakness in external rotation, they have night pain. We can also say if all three variables are positive that they have a positive 9.84 likelihood ratio, which in my world, that's close enough to 10. And we're trying not to, we're trying to save on imaging and things like that in today's healthcare society. So spot on. I think combining concussion tests and measures, because there are so many different trajectories and facades of this injury, I think it's just a brilliant thing that you're doing.
Well, yeah, and again, I happen to be interested in it, but also there was some good infrastructure for me in place to kind of learn some of these things during grad school, and it's certainly continued. I find value in it because the data has shown that it's a worthwhile tool. But I also think that there's a lot of pretty clear practice implications for people that are using, different concussion techniques, where, some of our studies have been in, motion analysis laboratory, which I don't know any ATs or PTs or anybody that routinely uses a motion capture lab for clinical purposes. It's not a real cost feasible type situation, but using some of those concepts where, can we combine a balance test and a cognitive test and see how these patients are doing, or how they're responding to rehab, or if they're ready to return to sports or school or things like that. I think that there's a lot of different applications at the clinical level for these.
Yeah, David, that's so important too, because, at the end of the day, we're in the spirit of the Olympics right now in Pyeongchang, South Korea. We just had Jeff Kutcher on, and Carolyn Baxter. At the end of the day, I don't know if you've seen the Grand Slalom, the women's downhill ski, but they basically had 26 skiers. I think 25 went. They went to commercial. They were like, well, I forgot the athlete, but she's got a gold, another gold, and so on and so forth. And then the Czech, I think it was the Czech Republic.
Yeah.
Yeah, she borrowed like one of our American skiers' skis. She came late to the event. She was a 26 skier. She's a snowboarder. And then 1/100th of a second, she came in first for gold. And she just started skiing like 2 years ago because she's a snowboarder.
Yeah, pretty amazing.
Right, though? So, if we think about dual tasking, these athletes, these high-level athletes, but then I also compare them to people working on the line. Like, they have to be quick and accurate and very specific in their work. We see a lot of injuries from physio, from like repetitive use injuries and things like that. But it's no different for our athletes and the dual tasking. Like if we're calling a play on the field, blue 42, cut left, you got to make sure your player knows what left is and they can process all that. So I really respect the work that you're doing with the dual tasking. What are you seeing in terms of dual tasking and injury and, people reporting late? What are you finding in your research in a whole?
Well, I think, from a measurement perspective, I think that I've kind of taken the approach of how do we longitudinally kind of monitor people on a variety of different clinical measures and what is going to be useful for you to do when you're assessing patients. And again, I think using this kind of multifaceted approach where, as you've talked about on this podcast and on Twitter and things like that, it's never going to be one specific thing. And dual task, a lot of the paradigms that I've used have been kind of a motor or a gait task and a cognitive task, but it doesn't have to be limited to just that. There's different functions that we can combine and assess kind of in tandem that are going to give us information about how somebody's performing beyond if you were just to say, test each of those individually on 6 different tests. So that's one thing, and then I think the other thing is kind of understanding the overlap between different systems. And for example, we had published a study that looked at the overlap between gait deficits, or using some measure of gait performance as well as convergence, and we see that the visual system overlaps with a lot of other systems in our brain. And so if there's deficits in one area, perhaps there's deficits in the other. We can look for those different areas of dysfunction that are causing some of the problems for people. And then that hopefully, and we're probably a little ways away from this, but that's going to be what dictates our treatment paradigms, especially for you in the PT space, of what are we assessing, then how are we going about trying to rehabilitate that area of dysfunction, and then how are we assessing the effectiveness of that rehabilitative protocol. And those are definitely the things that kind of we're working toward a better understanding of right now.
Indeed. And our listeners are probably going to get tired of hearing this, but, our brain's pathways are greater than 2/3 of our brain's pathways are devoted to vision. Right. And about 70%, so the majority of our sensory input for our spatial environments come from our vision. So, very Norman Doidge-esque. I'm a real big fan of his books. He has the one that The Brain That Changes Itself, and a few other just great reads. And he really talks about, muddy in, muddy out. If you're not inputting information accurately, you don't output 100% of the information that you take in. So that's so important, especially when folks are on the field or in the line, or having to dual task in our everyday lives. So, I love that component that you've, twisted into your research.
Yeah, thanks. And again, I think that you're totally right. The challenge is understanding, what it is that's wrong with the person. I think as a or I guess maybe wrong isn't the correct word, but what area of their brain is not functioning at an optimal level. And when I started doing this, we were looking at measures of motor cortex function, for example, and is that where there's some sort of problem and in the output down to the muscles that's actually controlling dynamic balance during gait, and then there's some sort of interference that then comes in with the addition of a cognitive task. And I think from a research perspective, it's okay to paint that picture and try to understand it, but even beyond that is there are so many things going on. It could just be that their vision isn't functioning correctly, and so that incorrect input is altering everything downstream from that, and that's causing the gait instability. Again, it's a very complex problem, and I think for me to say that we'll ever fully understand it at the individual level is probably pretty naive, but it's certainly interesting and a lot of work to be done, which as a researcher is exciting for me, because I think that we'll make a lot of progress on these topics in the next couple of years.
Yeah, and you're one of the few researchers out there, David, that are really just doing this very well with your peers, and really from a person in the trenches and doing this, day in and day out. We're very appreciative of your work, because this, I think, is going to change the game from here on out. We've seen. In medicine, when we don't know what to do with someone, we either send them down 2 trajectories. Usually that we allude that they're malingering because Dr. Schwartz, can't figure out what's going on with them, so they must be faking it, right? Or we send them to psych because we can't put our finger on it, and it's all in their head, which, it is, it's their brain, but not from a straight up psych standpoint. Right. So the fact that this article was published in CJSM in 2017, and that you're looking at near-point convergence. You're also looking at how that affects gait. Again, with concussion in the last 100 years, and certainly within the last 20 years and 10 years, the last 5 years, we've exponentially grown in our research and white papers published. So we're starting to get evidence-based medicine for concussion, but by all means, we really still have no evidence-based medicine for concussion. Most of our work is historically consensus-driven and based. So we have folks like David doing this work for us so that we can be evidence-based, and that's so we know what we're looking at, so we know what we're looking for, so we know how to treat this concussion, which we now agree upon internationally, and that is a treatable injury and a rehabilitative injury. So just kudos and good work all around there.
Yeah, thanks. And again, I think from the rehab, some of the work that's ongoing that we're trying to understand is, particularly for young athletes, you remove them from everyday life aspects like school and sports and things like that. that alone is probably enough to induce some of the symptoms that we ascribe to concussion. So I think that it gets back to concussion is a pretty poorly, or at least concussion symptoms are non-specific. And so going beyond that and understanding what sort of quantitative outcomes can we use, both from a research perspective and from a clinical perspective, to see are they truly getting better with these different rehabilitation protocols, exercise being one that I'm particularly interested right now that we're just getting off the ground with some work.
Yeah, and I just started. You're welcome to the club. I just started a club called Team BDNF.
Oh, nice.
for our listeners that aren't aware, brain-derived neurotrophic factor, which is essentially a protein that bathes our hippocampus and helps us with our memory formation and lets them stick. We joke about that in Just Now, but we do know that low-load exercise and cardiovascular activity is just a brilliant thing for the brain. It's like Miracle-Gro. So we no longer, tell our patients to rest longer than 24 to 72 hours based off of some systematic reviews by Grant Iverson and Silverberg et al. But yeah, you're certainly on the right track there, because I really believe that exercise is the best medicine, and there are just so many benefits, especially with, if you look at UPMC's 6 trajectories, you're looking at the cervical spine, ocular, motor, vestibular, cognitive and mood, anxiety, and post-traumatic headache and migraine. 4 of 6 of those are up the physio's alley for both evaluation and treatment, because we know this is a rehabilitative injury. But then we also have to add a 7th, which isn't talked about or published as much right now. John Leddy and all are doing some great work at Buffalo about exercise and autonomic dysfunction. So you let me know when those papers come out, and we'll get you right back on here.
Yeah, definitely. And a lot of the work that we're just starting is kind of based on some of the conversations that I've had with John and reading his work, obviously. And so we're just getting off the ground with some randomized control trials, trying to better understand the role of exercise and the kind of the dosage, how much is an appropriate amount, and then also looking at those individual factors, how much is a good amount for a 14-year-old girl versus an 18-year-old boy, looking at the effect of age and the effect of sex on those quantitative outcomes, I think is really where we're going to need to go in order to prescribe different treatment protocols for people. So again, we're just getting started. So we're probably about 2 years away from anything like that. But in 2020, I'm happy to come back and talk on some of those studies.
Exactly. And our listeners have heard this before too, but on average, from the work that David does, and we ingest, I'll say, the ivory white tower of Ph.D. research, it takes about 14 to 17 years for the research that David does in his lab, in his office, to get translated down into the trenches. So the Concussion Corner podcast, what I'm trying to deliver to you, is stuff that, yes, we still need to do research on. We still take an oath to do no harm for our patients, but in fact, we are actually doing harm to our patients that are actually, we're telling them to just rest and sit in a dark room and cocoon themselves. That's actually a harmful thing, and it's proven to be with MTBI and concussion, and those 2 words are synonymous right now in 2018. So that's really good work. In 2014, David, we have about 6 minutes left, just so our listeners are still leaning in with us. Excuse me as my voice goes away. But in 2014, you had the American Journal of Sports Medicine, volume 43, number 3, for folks that are interested. I'll place them in the show notes. But you looked at adolescents demonstrating greater gait and balance control deficits after concussion than young adults. I was wondering if you can comment on some age and sex data that you found throughout your research.
Yeah, again, I think what we're understanding is concussion is so heterogeneous, but also the effect of maturation across adolescence, as well as just kind of the body composition of people certainly affects the outcomes. With that study, I think what we were trying to understand is a lot of the literature, particularly on dual task and gait, had been in collegiate athletes. And I totally understand why. It's a pretty easy population where a lot of research is conducted on university campuses. But trying to extend that to say, do outcomes differ for younger kids relative to older kids? and young adults. And we did find that the adolescents demonstrated worse outcomes both initially as well as throughout the following 2 months post-injury, where they weren't able to walk and think essentially in as stable of a pattern as the young adults, which kind of suggests that perhaps there's more vulnerability to the effects of concussion during adolescence. And that aligns with research from a variety of other researchers and paradigms and testing techniques and things like that age group seems to be particularly vulnerable, I guess is the best word. And then on the effect of sex, we did publish one paper in Gait and Posture last year, I think in 2017, that just looked at, adolescent boys and girls and some of these dual task gait measures and finding that, yeah, there are some differences, and we don't really fully understand why they are different. But at least, we're saying that boys probably shouldn't be treated in the exact same way as girls. And that kind of spurs on some new research questions, one of which I'm working with some researchers, Inga Corte and Alex Lynn at Brigham and Women's Hospital in Boston, to do some neuroimaging work to understand truly the functional and the structural differences between male and female athletes. And that work also just got off the ground this fall. So that's certainly a big area of interest moving forward, and something that I'm hopeful that will make an impact in the clinical decision making of people that are prescribing treatments or managing the injury or just tracking recovery to say, how should we treat this girl? Is that different than how we should treat this boy? And I do think that we can't have this kind of one size fits all approach.
Indeed, and I'm really looking forward to from looking at like a hormone standpoint as well. In both girls and boys, we've had some research done by Jeff Bazarian out of Rochester and a few others. Yep. Looking at hormone in females and kind of where they are in their menstrual cycle and things like that. I anecdotally, as clinician, I'm really looking at these kids' maturation factors, their coping skills, their level of resilience and grit, their support system at home from a full biopsychosocial model. What is their premorbid history? All of these things play a factor, and I learned from my own concussion in 2013 that, I was treating concussion patients, so let's just put that out there into the world. But right. Me as clinician, right, me as Dr. Schwartz, I was not able to, as patient, you're unable with a brain injury or concussion or MTBI to subjectively express the what and how you're feeling. So I think that's also a big thing for our kids as well, potentially coping strategies and just not having the language or abilities to express what the heck they're feeling.
Yeah, certainly. And I think that gets to kind of what we touched on earlier with being able to assess the whole person and not just assess their symptoms and a neurocognitive test and a quick balance test. That is probably not painting that whole picture, but then also understanding the time demands and the resource demands that are placed on clinicians. And really what I'm interested in is, okay, what are the factors that are going to influence outcomes, the most key factors, and then what are the measurements, and then how do those two things in combination dictate the treatment or the management strategy? And I think that it's going to differ so much from person to person, but being able to assess those different tools and put them in the hands of people is really kind of what we're trying to get toward.
Indeed. And, I have to let you know that I do use this article from CJSM in 24 or AMJSM, American Journal of Sports Medicine, when I talk about, people ask me about driving all the time. Like, what do you tell these kids with driving? What do you tell the older folks with driving? Oh. And I bring back to this article. I'm like, listen, we have a few articles out there now, I think 2 or 3 that I think are pretty decent. But I talk about, this article with your adolescents, with concussion having displayed significantly greater loss of center of mass, medial to lateral displacement, than did your adolescent controls with a P of 0.001. And I say that we see that consistently in the literature. While it's minimal, we still see it in the driving literature that people are having lane change deficits and they're not staying in their lane with driving, which hello, that's a danger to everybody.
Right.
So, again, I think this is really where the future, the work that you're doing with dual tasking, gait control, and, combining ocular motor convergence, assessments with all of that, combined with, all the great research that's going on out there. I think combining all of this is just going to be so powerful in the next 5 years. I think we're just going to see just a wonderful trajectory of all the work that you've been putting in.
Well, thanks. Yeah. And again, you put papers out into PubMed or wherever. You never know who's gonna look at them or who's gonna read them. So I appreciate your kind of the fact that you're reading them makes me feel good.
That's good.
But yeah, I think that understanding, particularly in adolescence, the effect that concussion can have and the way that it affects that person and the people around them certainly is another area that we're kind of just scratching the surface, and whether they're a danger when they're driving or whether they can't effectively switch between two different tasks as fast. I think there's a big range of things that we still have to discover, but they're all equally important to understand and try to understand.
Indeed. Yeah. And just such good work. So, we're coming up on our 30-minute mark here, David. So what's the best way for folks to reach out to you? I know you have a Twitter handle. What's the best way for you?
Yeah, Twitter's probably the easiest, direct message or whatever. I check that pretty often. It's a good way to interact with other like-minded professionals. I really enjoy seeing what other people are doing and try to promote some of the stuff or that point to the stuff that we're publishing, but also promote the work that other people are doing in the field. So yeah, my handle is Howell, HOWELLDR, and my wife tells me that she thinks that people think it's doctor, but my middle name's actually Robert, so it actually stands for David Robert. But yeah, so that's probably the easiest way. And if people want to reach out via email, my email address is david.howell@ucdenver.edu. I'm usually in front of my computer, so I usually try to get quick replies to people because I know that if people are interested and have ideas, and particularly on the collaboration front, I'm always interested in working with like-minded people that have great ideas and learning from them and understanding how we can best kind of approach some of these problems that we've identified today.
Awesome. Well, it was so great to have you on here today. I know we're going to have you on for more for sure. And I hope you have a good day, and I'll let you know when we push this thing out for you.
Awesome. Thanks so much, Jess. It was a pleasure and really an honor to talk with you and be on the podcast. So thanks again.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.